Professor Marini to moderate this session. Also, if researchers want to ask something to clinicians, we have just two, but very good too.
And female, so I think we've got the right representative of this disorder. So yeah. So yes, I am a clinician, so I'm happy to moderate this session, although I don't know much about it and I don't fully understand. So I guess we can start the discussion probably just amongst the basic science information and knowledge you just shared with us today. And also, yes, we're happy to, answer any, we'll put together any of our clinical knowledge and maybe, yeah, we get a glimpse into the basic science and we try to bring you back to patients. And so, yeah, I don't know. Anyone who wants to make a comment and start this discussion?
I have a comment. I mean, I think that it's a super interesting day, full of different research for so many aspects. I guess one question is how we could try to really think how to best translate all these kind of findings from the basic science to the patient, given also the clinical variability, the different evolution in adulthood, the lack of really a kind of tailored treatment for the various aspects of epilepsy and the kind of behavioral cognitive difficulty. So I think there is still probably some lack of uniform direction. I don't even know if this can exist, but I don't know, maybe interested to see where probably whether we could establish some priorities or some directions. I don't know what's your view.
If I comment on it from a different perspective, so how to design a clinical trial so we have a chance to succeed, and we discussed it a lot when we were publishing that clinical trial, which I just quickly mentioned, because apart from what we learned from the ganaxolone, we also learned that this is really a very difficult disorder to design any clinical trial. And I think that's where we're probably lacking still the information which can be gathered through maybe the registers or through the patient associations, that we know very little about natural history, because we, or at least Mariners, really struggled to find eligible patients for the trial, because the seizure diaries or the information about the seizures was so incomplete and it was so variable that it was very difficult to choose which patient to include in the trial, because you can have clusters of seizures in a 6 months and then you have 2-year pause. So how do you know and how long the clinical trial needs to be? Because anything we will be trialing, on patients, that these patients, we don't have enough information or we don't have enough patients where we could actually design a well-powered clinical trial. So I think we heard it from every presenter, whether it was mouse model or there is a human patient, that it's highly variable. So my question is how we can leverage the patient associations and the registers to gather as much information about the patients, the seizures, so we can design the best possible trial, because sooner or later we will hit it. Either it's going to be ASO, it's going to be another agent, whether it's for sleep.
Yeah.
How do we do it in this super difficult disorder?
Yeah, from what we saw for the number of sessions we observed, certainly early age, early on, I mean, the early phase of the disease so the disorder is the one that is more active in terms of the epileptogenesis. So if we should be targeting small children, because they have more frequent clusters of seizures. So we know that over time the clusters of seizures tend to disappear or to become rarer over time. So that's certainly. So that's why I think probably the if there's any ideal patient, are the young patients, the one at the beginning at onset. So,
The drug companies hate that.
sorry.
The drug companies don't like that.
I know,
But that's,
I understand that, but like, you know, now we have this new repurposed medication that we're using for the syndrome, which is fenfluramine, Fintechla, that is being become available here in Italy, and it might become available and we might be able to use it. And the same thing, you know, they don't want to use it in small children, but you know, in this case, I mean, we know that we need to use it in small children, and that's the obvious fact. And so, I mean, I agree with you. We need a longer period of observation because
Yes.
like normally the clinical trials is like, you know, a couple of months, 2 or 3 months, but we need the initial phase and then the open access label, and we go on for at least a year to have at least a long enough period of observation for clinical trials in this situation. Yeah.
Or, I don't know, we need to find a different outcome measure or focus on
Yeah.
a different readout.
But the thing is
Not that
also,
seizures.
yeah, seizures are important, and also if we look at we could go for the cognitive function certainly, but that is even more subtle. And what do? Do you measure the IQ, how many points you lose, or it's really not easy? So the obvious what parents see at home is seizures. So I think they are in a way important measure. We just need to target the right age when we do the clinical trial.
And then eventually you could stratify
Yeah.
definitely seizures for the kind of youngest set, and then more as we know the kind of psychiatric side later
Well, that's,
on.
yeah, later on.
With the data, for example,
Yeah.
and the mouse model that they were presented, and the fact that
Yeah.
in reality the effect of the loss of function persists. So
Yeah.
it makes
I
sense.
see that the protocolline is also expressed in the glutamatergic neurons. So I just wonder whether we could go for medications that actually modify the glutamatergic pathway. For instance, brainstorming perampanel, which is this new medication. It works on the AMPA receptor, so it works on the glutamate receptor pathway. So I don't know, I just had a thought before. That's an available medication. It's an anti-seizure medication. I don't know if that makes sense, or
have you tried it?
No, I haven't. No, I haven't. No, I just thought about it before when I saw the presentation on the glutamatergic pathway and we presented it. So I thought maybe we could, because we know that the benzodiazepines work. They're GABAergic medications, anti-seizure medications. So maybe we could, try and the other pathway, the glutamatergic pathway. I don't know.
We cenobamate would also target excitatory neurons.
Yeah.
Because 8A.
Maybe the mouse models can. But no, the mouse models don't have seizures, so there's no.
Yeah, you go treat the patient.
Yeah, that's usually the patient not us. Yes. Yeah, I'm sorry. So yeah, I think of course for the families and that's what we heard this morning. They're really interested in having a treatment that is as early as possible and as curative as possible. Whereas we are at the moment just treating the symptoms when we see them. So it's a bit disappointing. So that's why your research is.
So what currently seems to work the most? I mean, when we looked at them in some of the original papers, the levetiracetam seems to work the best. But is because
we think
people
that
is the most frequently
we think
trials,
that clobazam, which is freezing in our country, so is the benzodiazepine, is the one that really works the best. Absolutely, number one. Benzodiazepine. They can be treated. They can be sort of given chronically, like every day, or you can use them on the acute phase when the plaster comes. And so that's what some families do. They might have just the, I don't know, maybe valproic acid or even levetiracetam, and then during the acute phase, you get the clobazam acutely, like 3 or 4 days, and so that's so we can distinguish the different kind of treatments: is the chronic treatment and the acute plaster treatment. In our opinion, I mean, that's Simona and I, because we sort of come from the same school, we don't think that levetiracetam is the best medication because it doesn't really help seizures, and also it has a problem with the behavior. It's a drug that really has a side effect that of causing some behavioral problems. And so considering that we start with patients that do have behavioral problems, it's like, you know, the cherry on the cake.
So it's exacerbates?
Yeah, I think so. I mean, but then again, I have to say that we heard from patients this morning from the families that it's really certainly a highly used medications. So they use it a lot. And I think the Germans used bromide a lot.
Yeah.
That was in one of our first paper when we reviewed all the treatment. That's mostly Germans. They use bromide. And some thought that bromide was very effective. I don't even know the action of bromide as it works.
They use it for days sometimes, but I mean, it's very effective, it's just got a lot of toxicity.
Yeah, it's very toxic, yeah.
But you just kind of answered your own question, because clobazam's acting on inhibitory systems.
Yeah.
So,
Yes.
yeah, that's
We
important.
thought, yeah, that's what we thought, you know, certainly the benzodiazepines are highly effective. And even if when the patient comes in the status epilepticus, then we give you know, continuous infusion of dazolam, which is the most used benzodiazepine. So yeah.
I think there is also a very interesting thing because, for example, you said that some patients might stop having seizures for 2 years and then they have seizures again. And then we also have this observation that with the onset of puberty, in many cases, seizures will disappear. And I wonder whether you have a developmental problem where the substrate has been altered during development, and that's why it's going to cause the seizures, or whether the substrate is not that much altered and particular stimuli. It's just in a very precarious equilibrium, let's put it that way. It's not robust. And then you can tilt it into seizures much easier. You know what I mean? Whether there is like an underlying defect that maybe cannot be fixed, or maybe yes, I don't know, but if it happens very early during development, it will be very difficult to fix. Or whether you can still have a working system, but it's just much more unstable.
It's like, you mean it's a matter of threshold.
Yeah, no, in some ways that's epilepsy in general,
Yeah.
because that's the
Yeah.
unpredictability is a really common feature.
Yeah. Certainly, I mean, what we see with the classes of seizures on the protocol 19 girls is that the infection, even, you know, like an illness, and they're unwell of some sort, you know, maybe not even the high fever, that really triggers the cluster. So there is, you need something on top of this threshold, which is really low if you think of like other excitability of high in terms of seizures, and then, you know, when something it's added, then the cluster comes on. And then we have the disappearance of seizures in most patients during puberty, so that is something to do with hormonal changes, as you, Joseph, showed. And that was the underlying idea using the ganaxolone, I think, yeah, which hasn't really proven to be that effective, I'm assuming, yeah.
Yeah, but there are also the corticosteroids are affected. I mean, these girls do have different levels of corticosteroid stress hormones. I think that's what was the finding of Giovanni Virginie.
Yes.
That whole system was altered, and that was not re-established when the drugs were administered, just the menopause was correct. stress response pathway
It's a stress response, yeah.
seems to be significantly affected because it looks like these girls are already
Mm.
on a high
Yeah.
alert
Yeah.
and they need only the tipping point.
Yeah.
So it would be nice to have a second hit model for the mice.
Yeah.
If you were to do something to manipulate hormones to increase seizures, what
Yes.
would
Yeah,
you do?
you need a second hit. Yeah,
So-
it's like the Dravet model, the SCN1A. The second hit is they warm up the mouse because the fever.
Yeah, we tried that and
Uh,
it doesn't cause spontaneous seizures. We
Yeah.
tried some chemoconvulsant.
Okay,
It doesn't.
yeah.
But hormonally, what would you try for a second hit?
Not just not fluoxetine, but was the inhibitor of these enzymes. Your president is, your past president has been on it. I think it's also it's an alopecia drug. Is it fluoxetine?
At an antidepressant
Yeah.
medication is a
Serotonin
certain
reuptake.
drug,
Yeah.
fluoxetine.
Serotonin reuptake inhibitor.
Yeah,
Does it
No,
iron?
fluoxetine will be positive, but not that was.
Yeah, it's,
Minoxidil?
I will come to me.
yeah.
With an adjunct steroid? Or
Yes, blocking steroid and neurosteroidogenesis.
Oh, okay. I think I did try the fluoxetine blocking the reuptake of the serotonin in a couple of patients that it didn't work.
Didn't help.
No, mind you, they were really severe, so I
Yeah,
guess.
yeah, not just SSRI, they have another version.
Lorcaserin, you guys got that drug?
No.
That's another one.
is there any evidence?
Because you don't have metformin yet, or you do?
This morning we talked to the family. There was one patient who actually is currently taking the fenfluramine, and the patient is doing quite well. The number of clusters of seizures has been reduced, not disappeared. It has been, yeah. And then there was another patient with also some more recent kind of combination of medication. So it's the Epidiolex with the CBD and not the clobazam, which is what it's advised here initially, but it's the clonazepam. But yeah, so that also seemed to help.
Because it would be great to have some of the more recent assessment of these medications, so even the scientific community
Yeah.
have a selection of top 10 drugs which perhaps we can take and we can trial with our models.
I think the program would be very interesting because,
Fenfluramine.
yeah.
And I would give it a go to the perampanel, to the glutamatergic drug. I think that it's a completely different medication that really targeted a completely different pathway, but it's also very easy to, you only take it once a day in the evening, so for families and patients is more easy to use, but also fenfluramine, yeah.
With regards to the new studies, are there any studies in mind? Because I think all the ones I've seen are good. Has anyone checked the animals? But there is also this imbalance
In mice.
in mice.
The problem in mice when we looked is that pathway is different. There's twice as many genes and the metabolism is different. Whether that explains why the mice don't get these clusters of seizures because they are more buffered against that, simply because they are more robust in inhibition, in generating these metabolites.
Yeah, the second hit.
That's the idea.
You can remember it.
I guess the family would be interested in gene therapy.
Always. It is a tough disease.
It's a tough
No, we did have a discussion a few years back, and I remember we were talking about, of course, ablation, BCDH19, or
Yeah.
supply of wild type BCDH19 as two strategies. But it sounds like that maybe ablation is a better strategy than
Okay.
delivering
Okay.
a fresh
So
one.
to remove the second PCDH19.
So remove the wild type, yeah.
Yeah. So I have no PCDH19 at all.
Yes.
Why do you think it's best?
Technically, it's probably more achievable, and you probably tamper less or you create less damage rather than delivering a new multi-use virus or something. And yeah, but that's just my question. It's not necessarily a statement, but based on what I see, some of the companies, and we talked with Carla, Praxis is trying to ASO down-regulate PCDH19 rather than delivering. I don't know whether anybody's working on like AAV gene therapy with PCDH19. It's mostly ablation. But that's also a good question.
More universally applied, because you can just silence the gene, whereas if you have individual mutations and you want to fix each of them.
The other point is that if you overexpress, so you perform gene therapy adding a wild-type PCDH19 protein, you can choose the cells will be infected. So you will have a cell mutated with the new PCDH19 protein, but also wild-type cell with other wild-type PCDH19 protein. So you will create a mix of overexpressive cell overexpressing PCDH19 and cell with the physiological level. So again, you are not, I think, the best way to try to reach the reverted phenotype. So the idea was just to mimic the healthy homozygous patient. So it's the most feasible way, in my opinion. We try to reactivate the with the Cas9p 300 cancer plasmids, try to reactivate and finite both allele of the gene. But the main problem is that in this specific case, you have a bar chromosome, so the promoter is very difficult to be reached by the plasmid.
Yeah, because it exists, right?
Yeah, it's very impossible. So it's very hard to. We are able to reactivate genes that are as a methylated promoter, but just a methylated promoter. No, all the chromosome is methylated.
Yeah,
So
the
accessible, the site is not accessible.
Yeah. But that's good. I guess that's at least we converging on the silencing rather than overexpression, because with the X inactivation and we still don't know whether overexpression is detrimental. I don't know, there's very little evidence to tell us whether overexpression does anything. It sounds like maybe not, but we probably don't know. We should say.
Yeah, we did one experiment where we overexpressed, but we probably saw a change in migration, but we could never replicate.
And overexpressing membrane proteins is always a problem because of all the processing that needs to happen to the protein. So if you put too much, you might impact the normal processing machinery of the cell.
Okay.
And then you might create secondary things.
Yeah. Of course, assuming that not having the protocolouring at all is better than to have this natural mosaic stages when there's some cells with mutations and some don't, and that's what we think that this is the explanation for why they.
Yeah. So in that vein, we found one patient with PCDH19 duplication who had epilepsy, but they also had an in utero insult. So, have you guys seen any duplication?
A male patient? A male patient?
No, this was a
female.
Have you guys seen any duplication?
Wouldn't that extra chromosome be as well? Or it was that application within the normal? It was not that two X chromosomes. It was that application.
Is that entire gene duplication? Yeah. I think I heard about one case, but I think that was eventually explained by something else.
Yeah, so it sounds like, yeah,
And that was entirely gene duplication.
yeah, just trying to get the imbalance.
It's probably very rare events, but
Never heard of any duplication of PCH19. I don't know about you, Simon. I'm just never come on.
but that region as a whole is duplicated.
Yeah.
So, but it's part of more complex
Yeah.
syndromes. So it's hard to tell.
Many genes included in the duplication.
And as clinicians, you haven't found any homozygous none feelings? There's no phenotype being described.
I think we would need to go to consanguineous populations.
Yeah.
We need to ask our colleagues in Middle East, Fozan, Al-Quraysh.
Yeah,
Well,
you might.
That's
Yeah.
No,
Not that we've discovered, but you're right. Yeah, we need more consanguineous population.
all the consanguineous populations by
Yeah.
chance.
By chance, yeah. It's like for this gene PRR22, heterozygous mutations are really mild. Homozygous mutations are absolutely. Yeah, SN1B2, yeah. But no, not for
because we're assuming that eliminating it completely in a female is going to be the same as eliminating as the males that lack it. But this is really an assumption. I mean, it looks very likely.
Yeah. We did say though that we think that males are not, they don't have epilepsy, but they're probably.
They're not normal,
Yeah, yeah, they're not normal. That's what we discussed with Ingrid and I think that they're not normal, and Joseph keeps saying that they're not normal. They've got
Well, I showed only a few measures how they
psychiatric.
they just don't understand.
Yeah, sort of obsessive compulsive behavior and things like that. Yeah.
That's probably something which would be good to look into.
Yeah, that's it. That is the starting point. Yet, they're slightly.
We are all different.
Yeah, the threshold is slightly different. Let's put it that way. Yeah. Very nice.
Yeah, the other thing we don't know is if there are other protocoherons compensating, whether you get rid of it in adulthood, may cause problems.
So that's an interesting question. We discussed it, and I saw it here from Professor Zvijana's summary, that there is no delay, cognitive delay, before the onset of seizures.
Well, that's the majority of patients, not all of them.
So the question is whether
Some
there
might.
is
Some have no seizures and intellectual disability, right? You don't have to have the epilepsy
and
to have
some-
the intellectual disability.
Yeah, some might just have sort of a borderline or so not doing great. Or,
So whether the development is delayed or changed
Yeah.
before the first seizure.
there are some patients in whom the development is not quite right, even before seizures.
Because the question is whether it is a true developmental disorder, because I think we had this debate about Rett syndrome. I mean, Vianney showed that if you born without and you re-express it, even postnatally, you recover pretty much everything. So it is not true developmental because you can rescue it after birth.
Yeah, same with SCN1A.
So the question is whether you can, whether PCH19 is like that, because I guess that's also an unresolved question, but it sounds like that it can be fully, potentially
Absolutely.
rescued
Yeah.
after birth. So we don't need to even speculate
Yeah.
that it's truly developmental or that we need to treat in utero or anything like that, even though that's probably wouldn't come here because it's not fully penetrant and we don't understand what's driving the penetrance or not.
Yeah.
I mean, we try to look a lot at the methylation signatures. Maybe we have something that we haven't pursued it, which would predict a person, let's say newborn, with PCDH19 variant, whether they're going to be penetrant or not penetrant, which they have 80% chance currently, I think. But if it can be rescued, and we heard that from other speakers, or the disease can be triggered later in life, then it's not necessarily neurodevelopmental, I mean, in strict terms of that description. Which kind of changes, I guess, probably the strategy for intervention.
Whether you have defects that have happened during development and they're always there, or whether you have reached a state that it's more or less normal but unstable, which are two different things. If you have a defect, you need to correct it. If you have something that can work but it's unstable, you need to keep it stable.
Because that has something to do with the redundancies, the system, and
Right,
whether it's
right.
or not.
I mean, it's hard enough to make a flock rescue when you have a good phenotype in your mice, but when you have mice without good phenotypes.
I guess we do include PCDH19 as a developmental epileptic encephalopathy. So there is this developmental sort of issue that, in our point of view, sometimes we think, you know, it is developmental, but it's the epileptic encephalopathy that makes it more developmental problematic. Like, you know, the epilepsy has a huge weight on the severity of the developmental impairment. Yeah, but maybe there is also, yeah, there's certainly something that hasn't got to do with epilepsy, because not all patients that have severe, you know, frequent clusters, you know, go into the developmental phase, and the ones that don't have many clusters are doing better. There is no such a strict correlation. So on one side we have epilepsy that's really bad, and then we have PCDH19 mutation and it's also bad. It's like we consider it more or less like a similar model of Dravet syndrome, with these two things sort of go together, and they're not easy to separate.
Right, and it's probably likely that your exon activation pattern that is going to lead to more severe seizures is also likely to lead to more severe intellectual disability. Hard to unlink.
So, and what people think about those reports when they say that different mutations give different phenotype, slightly different severity. I mean, I'm not convinced, but
Yeah, that's not strong evidence, right?
yeah, because I noticed that about 2 studies which suggest that certain type of mutations give more severe phenotype. I don't know. I feel like it's probably underpowered, and probably the evidence is not very strong. It's probably not very important, but I guess it's a little bit important for the parents who may worry that, well, I have a child and with this mutation and it's more severe, but it may also be non-penetrant.
Yeah, but then again, if you remember, we had different twin pairs. You know, they're really the best model for this, because
yeah, the twins or the recurrent variants, so you see the same variant in 30
so we
people,
have
40.
a twin pair, identical twins, so carrying the same mutations. They're absolutely identical, very severe, very autistic, and then we have a twin pair, and you've got the cells of this twin pair. One twin is very severe, and the other twin is now living in Holland or somewhere else in Europe, going to university, and just a few seizures, and they have the identical mutation, and I'm assuming more or less similar background, genetic background. So I don't know. I think that since there are different twin pairs, I think there could be, you know, the best.
I think we have to remember that we don't know the real brain mosaicism of each of these patients.
Yeah.
So this is the point, and so you know that epigenetic modification happens during embryogenesis, and it's just chance. So we have no way to evaluate the rate of the brain mosaicism in each female. I think this could explain the variability between females, even when the genotype is exactly the same.
So what you're saying, it's unlikely that the variants
No,
can
maybe,
predict severity because
maybe
It's just more
yes,
complicated.
yes, for a proportion, but we have to remember that if we have 70% and 30%, it's very different between 50 and 50 or 80 and 20. And we have to consider that it's just a chance. And so each female is unique, even if share exactly the same genotype with
Yeah,
a
but
sister.
do we have a good evidence? Because I agree with you that I just talked to Jack about that because he is a good model. Whether we do have evidence that 50-50 is the worst case scenario and 70-30 is the good one. Do we have evidence?
No.
We still probably only.
Where is in the brain, so it could
Yeah, it's
be-
not just a percentage,
Yeah,
it's
it
the
could be
location.
random.
Yeah.
The other thing that we don't know, well, I don't know whether those have been sequenced, but I know it's highly unlikely that it would also have somatic mutations happening, that for some reason render one cell that has an inactivated chromosome with the wild type less efficient, and then you skew completely the whole X inactivation.
Then I think we have seen that the temporal lobe from the Polynesian part is particularly sensitive, and then of course if there is some clustering there of the mutation, then we have more expression of the phenotype, and we've seen the probably most prevalent type of seizure there, but then you have all that. I think there's so much level of complexity that it's very different to dissect, but definitely at this point about mosaicism I think is very relevant. So I like it, for example, yes, in one epilepsy, where now we have more kind of predictive tool where you put together some clinical features, some characteristic limitation, and you can somehow predict the severity. I don't know if here we have a possible, given all this complexity, that some of these, I have no idea how we could control for, such as the distribution of the mosaic variants within the brain.
Because one way to look into it, we tried was, of course, to have post-surgery material. I mean, some of these individuals do undergo brain surgery.
Yeah. There's certainly one.
They undergo brain surgery, maybe not even knowing that they have PCDH19.
Yeah, exactly. One of these patients is, we have, there's one patient from Verona, from Professor Dalla Bernardina. She was operated upon her focal epilepsy, and the operation was done at Niguarda in Milan. And then only years later on, when she was having seizures despite the operation, and so we performed the genetic testing, and she has a PCDH19 mutation. So definitely, there are several patients where the mutation has been discovered after surgery because they do have focal epilepsy, multifocal or
But sometimes they have cortical dysplasias. I mean, there's a small number of patients
There is
describe
one,
this as
there may be one, I think, but the specimen of the taken from this specific patient I know of doesn't really have any evidence of cortical dysplasia, but the tissue is at Niguarda in Milan, yeah.
because such tissue would be extremely valuable to perhaps ask questions about all these pathways we talked today.
Yeah.
X inactivation, gene expression differences, the technology is there.
Yeah.
And I don't know how we could actually get as a community access to these samples. I know they are extremely precious, but I'm sure there are patients who have probably undergone or undergoing or considering to take the radical step, because sometimes the surgeries do help. I mean, as I understand, they are one of the most successful treatments in epilepsy.
Well, not for PCDH19,
not for,
but
generally.
there are some patients who might be treated with BNS or vagus nerve stimulation, so I don't know if that, but we can't take any tissue. But yes, certainly if you wish, we could get in touch with the Niguarda and see if they have the tissue and if that can be shared. That's easy, yeah.
I will come back to you about that.
Yeah. And, yeah.
Go ahead.
No, sorry.
Changing topics. So.
Okay.
You go change it for good reason.
Yeah, so now I have a question about the intracellular domain variants that are thought to be pathogenic, and whether people think variants in the intracellular domain affect extracellular binding, or whether it's from the ICD going to the nucleus, or what's going on with it.
You mean missense variants?
Yeah.
I haven't haven't seen one convincingly pathogenic, to be honest.
Because there was a slide with 6 patients that from that group in the first talk. I think.
We collected some variants like that. We have the variants, but we didn't see any major readout which convinced us that they affect the function of the system.
Do you remember the paper? Which one was it?
That may have been my PhD student's paper.
Yeah, I can't remember.
The
First talk.
The first talk, but
That's
that's
what
the
we said,
second,
yeah.
Yeah, he said his list had 6, it was probably one of Nicola's papers, but it had 6 patients that claimed to have ICD.
There are people who publish variants in an intracellular domain which they then no. We haven't seen any convincing evidence.
Are there any in the constant cortex? Or
In the C1, maybe 1 or 2 variants. We thought at some point that those variants can give a different disorder, so that was because different mechanism. Some kind of dominant effect in males, but not females. If your model is suitable for that, or Maria Silvia's with the overexpression of the intracellular domain, maybe we happy to share those variants. If you were happy to test them, or it's not.
5 to 5.
Good discussion.
Yeah. I think we could take
So,
the rest.
one very quick
Okay.
last question, maybe. Many people try to do IPS model from these heterozygous females, and we try to reprogram. So have anybody successfully reprogrammed heterozygous female skin cells into IPS lines with the different chromosomes? You tried?
Yeah, we've done that.
Here's not males, yes, but females.
Yeah.
And you have different axes acting.
We think, and we did that androgen receptor assay, one time, but you have to do that with every experiment you do, so we quickly gave up with that, made the knockout and made mixes.
And then you make mixes.
Yeah, I think that's just the easiest way to go.
Because, yeah, I don't know, I think it was Alessandra show that localization of PCH19 to centrioles. Yeah. Claudia, yes. And the question is, well, we thought that was artificial, that it might be actually acting in a role, and the question is whether that's not the reason why sometimes these cells could
There's
We
someone
reprogrammed a bunch of patients.
is asking to make a question. Hans and yes, maybe you can talk. I think Ben Malenkopf is asking to make a question, but
Yes, I have a question.
okay. Please.
Is there any kind of a device or something that we can use through the night to help with the seizures or help detect oncoming seizures? My granddaughter does get fevers right before her seizures.
Sorry, we didn't get your question.
I was asking about devices that might help predict when a seizure is coming.
Oh.
Has this
Can you repeat?
there are some dogs that are capable of predicting seizures, like therapy dogs, like not experimenting. I don't know what they experiment.
No. They can pick up the earthquake, the dogs. But not seizures. Yeah. Sorry. Okay, you still there? I think
Yes.
we we didn't get your question. Sorry, would you mind to repeat it?
Yes, my granddaughter's seizures are, she gets fevers right before. Is there anything that we can use to detect
Okay, yeah,
a
I'm sorry,
seizure?
but yeah, I know. Yes, so we got the question. Yeah, I'm sorry, but not nothing as far as I know, and I don't know if anyone else in the audience. There is really nothing we can use to detect whether that specific seizure is going to bring on seizures or not. So, there is really nothing. I'm so sorry. Yeah, but we don't know really why. Sometimes seizures come, sometimes they don't. Um,
Benzos during fever?
I think we do start the benzos when we see the first seizure, not when we see just the fever. So
Right.
because sometimes you can have fever and no seizures. So I think we wait for the first seizure and then we start the clobazam. Some families some patients start the clobazam. Yeah.
Some parents I know anecdotally at this meeting tell me that they can tell when the seizures are coming.
Yeah, but they can we discussed it this morning. Exactly. Yeah, they do. They do. Yeah, the patient gets some quite hyperactive or changes the behavior, like maybe a few hours or maybe the day before, and we discussed about the possibility that already underneath in just a few neurons you start with electrographic seizures, but no clinical evidence. So that's a possibility that you have these so-called just electrographic seizures. So yeah, I guess.
Parents who have experience
Yeah.
can comment on it, because
Yeah, but
some parents said, I
nothing.
know when the seizure is coming.
But nothing scientific or systematic. Yeah.
We we do notice that with the change in her behavior. Also,
Yeah.
though, my
Okay.
granddaughter, she not only has PCDH19, she also has trio syndrome, the trio gene mutation. She has both. So we have so far not found anyone that has both. She just turned a year old in January.
Yeah. Not. I don't know of any other patient who has the same combination. Unfortunate combination. Yeah.
Well, it's unique, but there are other patients who have
Yeah.
PCD19 and
And
something
yeah.
else.
Yeah. 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 Thank you very much. And I think
Thank you.
it's 5 o'clock, and so I think it's time for me to leave the audience to you.
Just to thank everybody and hope to see us again in the next 2 years and with more and more results, hopefully. And let's keep in touch, of course. And I'm very happy because I've heard that some of you will be rest in touch during after this meeting, and this is the first aim of this conference. So please remember that in the name of our children. Thank you, everybody.